Okay, so again, welcome to this presentation. My name is Aniko Szabo, and I'm representing the Biostatistics Epidemiology and Research Design Group of CTSI. And I will be talking about how to work with the EHR data and specifically about defining the study cohort. Before we start with the topic, I have a few slides about generic slides about BIRD. And we are providing statistical support through CTSI. There are 3 groups that actually provide the support. It's both at UWM, at MCW, within the Biostatistics Consulting Service, and through the Center of Advancing Population Science. And the support is provided through BIRD mini grants. So they usually provide 4 to 6 hours of statistical support. And they are called mini grants because you don't have to pay for them and not because it's difficult to apply. So application is just really just fill out the form. And generally they are targeted at study design, thinking about analysis plan, sample size calculation, maybe some preliminary data analysis, but not major data analysis projects in general. Since I also work at the Biostatistics Consulting Service, I want to let you know that there are available assistance beyond the CTSI mini grants. And so we provide full service statistical support for with a wide range of issues. And we have 2 versions of work. We do fee for service, and we also have integration contracts with a variety of departments and divisions. And the benefit there that these are free to the investigator and funded by more centrally. And I listed there some of the departments and divisions who work with us, and if you are from there, I hope you know about this. But we are happy to help everybody else, except then we will have to charge for it. And the applications can go either through the email for help, and also, but in general, we will ask you to submit through iLab. And if you're at MCW, hopefully you already know how to do that. So going back to our topic, this is actually part of our spring lecture series, this talk. So we have 4 talks on related topics. Last month, Dr. Brazauskas was presenting about how to design observational studies more generally. And so today I'm talking about some specific details about how to define the study cohort. And then next month, Dr. Terimamo will be talking about defining outcomes. And in June, we'll have Dr. Huang talk about how to actually create an analytic data set from the EHR data. So again, I'm focusing just like one specific area. And more specifically, the objectives for today is to talk about the structure of electronic health record data, how to operationalize study inclusion exclusion criteria. So I'll talk about working with coding systems in AHRs, thinking about what's incident versus prevalent cases, and the concept of opportunity of information that we'll talk about more in detail. And at the end, I'll hopefully have some time to just demonstrate how you actually obtain the data for the identified cohort. Just click through the process a little bit. So before going into details about how electronic health record data looks like, I think it's useful to think about what's the context, how these data are actually generated. And so I like to think about like the life of a person, right, who from childhood to adulthood, and then they have some kind of illnesses along the way. So some of them like this acute illnesses, like red bars, then they maybe develop some chronic conditions, maybe multiple of them. Some of them may actually get cured at some point. And while this is happening in their life, they'll have various interactions with the medical system. So they might go to the doctor if they are sick. They also might go to the doctor if they are not sick, like for checkups, annual visits, something like that. On the other hand, of course, they might be sick and not go to a doctor. That also can happen. And while they're interacting, there are various things can happen. They have visits, they can get prescribed medications, they might be hospitalized, and so on. So this is kind of what's happening in the life of a person. But what we get in the records is some kind of time period, right? So this is the electronic record. And whenever there is some interaction with the medical system, some kind of records show up in the electronic health record, right? So but certainly if person doesn't go there, it doesn't show up, but it might be like person has something, but it doesn't show up in the health record because maybe they actually interacted with the healthcare system, but it was not our healthcare system, or maybe it was just Walgreens drop-in clinic and it didn't come up to the doctor. Or maybe actually at some point they transitioned to a different provider because their insurance changed or whatever, and now they are generating the records in a different health EHR, and of course we don't know about that. So kind of this is a context. It's really helpful to think about it when we think like this is what we see, this electronic health record, like this blue, but there's lots of other things happening in the person's life before, after, and there might be again things happening even during this time that are actually we don't know about. So more generally, some of the characteristics of HR data that makes it hard to work with is, first of all, it's always observational. It records what happened, whenever it happened, and we have no influence of asking things to get measured or something like that. And it's also really changing over time. So whenever there is a change in the system, there is a change in policies of the institution that, oh, now we should start doing something a different way or recording something in a different way. Quality improvement projects that make sure that things get recorded, and suddenly you have more information that you didn't have before. And this is all happening over time, right? So changing. Also, the data are not collected for research, but for other purposes. Typically HR, it's for clinical care and maybe for billing, but definitely, again, not for research. The time frame we see is limited. We're still kind of in a situation where it's limited by the existence of AHR, so you really can't go back very far because we didn't have electronic health records data. But also it's limited by the patient's relationship with the medical system. So if they move away, if they change providers, all of that might come. They may come in the system and they go out of the system, right? So this is all just like a snapshot, a window that we see of their health conditions. The other complications we always have to keep in mind that we only see events when they happen. So we see visits, procedures, whatever, but we do not see when things do not happen. We can kind of hope that if it would have happened, then we would have seen it, but we really don't see things not happening, right? Nobody records that. And the problem with this is, of course, that additional events can be missed, right? So maybe an event happened, but it's not recorded. So again, maybe they didn't come to our health system, or maybe they actually didn't even go to a doctor, right? But still something happened. It used to be that you couldn't even know if a patient has actually died, unless they died maybe in hospital, and then you would have a record of that. But that is now, at least in our databases, is mostly solved. So at least they've merging the death information. So at least deaths are probably not missed typically, but other kind of events definitely can be missed. So when talking about EHR data structure, so many people, especially if you have providers, can think HR is like the system, or, you know, if you've seen as a patient, people entering, doctor entering information, right? That's how it looks like lots of buttons and lots of screens that you can click left and right and enter information or look at information. But this is not really what we are talking about when we are talking about data extracted from electronic health records. What we are thinking about is more like what's happening in the background table. So we have various types of records within the HR. So encounters, labs, medications, vital signs, procedures, diagnoses. And so as time progresses, they are kind of these little boxes that I was showing in the previous slide, when they show up in HR, they actually kind of comes in a variety of types, right? So they're all different type of data that's get entered into the HR. And so this is, again, I think is a good conceptual picture to think about, that when things happen, they kind of record, records pop up in different areas of the EHR and different types of things. And often a same encounter produces many things, but sometimes just a few of them get populated at an encounter. And when we will extract the data, actually to work with it, it will look more like this. It's lots of spreadsheets, each having corresponding essential to one of these potential data types. So there is a spreadsheet for encounters, a spreadsheet for labs, a spreadsheet for medications, and so on, or actually multiple potential for some of these. And they have lots of numbers and codes, and there is maybe a patient ID, and then you can figure out the same patient ID in a different file, so it must be referring to the same patients, and there are all kind of numbers and codes, and that's actually the data you get out at the end when you extract data from the electronic health record. But it certainly is very big and complicated, and you cannot just run analysis on it straight up. So one thing we'll find in the data when you extract is that there are lots of codes, that every kind of piece of information is not just recorded, but it's coded, which is actually a good thing, because if it were just free text, then it would be really a nightmare. On the other hand, the fact is that there's so many things and so many different codes, it's really a lot of work to get familiar with it. So for example, with diagnoses, they use ICD-10 codes nowadays. There used to be ICD-9, and I hear that ICD-11 is actually already in effect, but I haven't actually seen them in EHR data, but I'm pretty sure will be popping up in the next few years. But again, some of these codes are nicely structured. So again, the ICD codes have a nice hierarchical structures, and some of them are pretty random, like CPT codes. I think there is no rhyme or reasons in them. Most of them are publicly available, but for example, CPT are proprietary codes, so you're actually not as easy to search for them. But again, everything has different coding, and sometimes even the same thing, like for example, procedures, inpatient and outpatient procedures usually use different coding. Not necessarily, but so you also, even for the same thing, you kind of get a mixture of coding, not only because potentially you get like updates of the same coding system, but also because they tend to use different things. It's also for labs, for example, it's good to know that sometimes you have labs, they use Loeng codes, then that's the labs that have actually the result also. So you would not only know that the lab was done, but you know what was the result. But CPT has lots of codes for labs, but when it is ordered. So you might, this one, you know, the lab wasn't ordered, but you don't know what was the result. Here, obviously, if you have the result, then you know it was ordered at some point. So again, to work with EHR data, you really need to get friendly with the codes that you are going to be working on, depending on what your study question, which parts. And it's very important to look up the documentations for them and really explore them. So I have some examples of how kind of one does that. So I recently had an example when somebody wanted to find the code for metastatic breast cancer, like diagnosis. And if you just search for it, and actually searching on the internet is not a bad way to get started, for metastatic breast cancer, it immediately pops up a code, this C79.81, but if one looks carefully, it actually says there that it's secondary malignant neoplasm of breast. And this actually means that this is not, it is the metastasis is in the breast. So it could be a cancer of another site, potentially the other breast, actually in the case of breast cancers, and this causes the new metastasis, right? Depending on the site. So this is not what we are thinking about when we want to have metastatic breast cancer. We want a primary breast cancer that has metastasized. So our investigator said, well, but there must be a code, because she takes in EHR when she's entering the diagnosis, there's just a drop-down option, and that's one of the options essentially to pick that, and she just selects it and it all enters code. So we actually went in the HR and look what happens when she selected the metastatic breast cancer drop to menu, and then looked what gets entered in the diagnosis. And actually what happens is two codes are created. Is that there will be a code for C50 dot something, which is actually a breast cancer code. So, so that's the original disease, and an additional code from the C77 to C79 range, like for example, this one, depending on where the site of the metastasis is. So it actually then kind of codes where was the original disease and the site of the metastasis. So that's how you actually would be looking for metastatic breast cancer. You would be looking of two kind of codes next to each other or in the same patients. So again, this kind of needed a little investigation, detective work to figure it out. And this is kind of very common that unless you are really a specialist in this, that figuring it out, it requires detective work. So an ongoing example I am going to use in this talk is light chain AL amyloidosis, and I'm working with that with Dr. Aniko Szabo. And so I want to just give a little introduction to this disease, because I will be referring to it multiple times. So this AL amyloidosis, it's a malignant plasma cell disease. It's pretty rare, with an incidence of maybe 14 per million annually. So in this condition, you have amyloid deposits in a variety of organ systems. And so different patients have it in different places. So it causes a wide range of symptoms, not necessarily easily identifiable. And so it's actually kind of difficult to diagnose. And the goal of the study was to identify what kind, before the AL diagnosis happens, what kind of other diagnoses in this associated with symptoms in these various organ systems that can be affected, what kind of diagnosis patients have, and what's the timing of this diagnosis. And so the basic study cohort that we want to pool is patients with newly diagnosed AL amyloidosis in some time frame. So that's kind of the setting. So step one, we need to find the code for AL amyloidosis, right? And if you search for that, there's a very clear and correct answer. It's actually E85.A1. There is specific code in ICD-10 code for it, and it is correct. But if you look it up in more detail, and actually I like to use this ICD-10 data website, which there are many data websites that for ICD-10 codes, but I think it really kind of shows very useful information. So what happens, you'll see that it's a billable code, a specific, and if I go back, hey, it was new in 2018. So wow, what happened before that? We know ICD-10 actually was before 2018. So we can go around a little bit more about the whole hierarchy around this code. You see that there is E85 amyloidosis and it has some specific subtypes. And after some clicking around, I found that E85.8, which is other amyloidosis, and currently is all red. It's not billable, so you won't not supposed to see it. But in 2018, it was converted to parent code, meaning non-billable code. And before that, it was actually the code you are supposed to use. So all these didn't exist before that, the 81, 82, 89. So until that, all of these were supposed to be coded with 0.8. So, and again, this is there are lots of kind of things. And I'm not saying that every code has such a weird history, but all of them have something funny happening if once you look at more carefully. So you really need to investigate what happens with the codes. So for example, a possible then definition to decide what's the code for AL amyloidosis, and again, referring to this whole area around it, not just the specific code. Maybe we'll include the specific code, some of these vague code, more vague codes that are other amyloidosis, this high-level other amyloidosis for his older cases, you know, this organ-limited amyloidosis. And potentially we can say, okay, and then let's exclude other occurrences of other very specific codes that are definitely not AL amyloidosis, but a different kind of disease. So perhaps big patients who have these codes, but not these. So in general, as I say, finding the right codes is a bit of detective work. It's very useful to start with looking at the literature, what others have done who publish in this area, right, using claims data, AHR data. So I think you certainly want to investigate what they used and see what you think about it. But it is always a good starting point because they hopefully also looked into it in more details. When you're using TrinetX, and I'll show you, it has actually a very nice word search for all the codes. I think I2B2 also does, but TrinetX really has a nice interface for it. So it can be a good starting point of what it is. It's also useful to look at the coders and look in the HR to see what happens. So, you know, they also know a lot of things, how something like this would show up in the code, how it would be coded. And you absolutely, I think, always must look up the code documentation, because there are sometimes unexpected, unusual things. They usually have links to other related or unrelated things. You want to check the history, especially if you have a study that covers a longer time period. You know, yeah, this is the code now. What was the code 5 years ago or 10 years ago? It really changes over time. So another issue with still with diagnosis, but not necessarily the codes, is that the same code can occur multiple times, and you usually really are not interested in the code. You're interested in the patient having the disease, right? That's what you are kind of substituting it for. So when you see a code, it could be an incident case, so when it's newly onset, right? So that's why the code is there. It may be an ongoing condition, so it's a prevalent case. Or maybe the code is there because they were trying to rule out that condition and they needed to justify testing, so the code is put there. So, but they might actually not have the disease at all. Or there was a miscoding, which is certainly also happens, that the code was there by mistake. And while I made it very nice and color coded, right, different colors for different things, unfortunately, the actual diagnosis codes are not color coded. So what you get is once you look at the data, is that you have this period for the patient's medical record, and maybe some well-defined code occurs multiple times. So you have to kind of look at it, or not actually look at it, but think about how will you decide, is it a prevalence, is it incident, is it a new subset, is it maybe a miscoding? So in this case, for example, I would consider, well, it looks like somebody has repeated instances of the same thing, and this very first one is probably when the disease started, and then the patient keeps having the same problem. So like first it was incidence, then it was prevalent. But what if I see this, right? So now it's kind of the same thing, but I don't see this period before, so I'm really not sure. Is it new diagnosis here, or did they have older codes, but I just don't see them? So probably I would have to assume that this is still prevalent, though I really don't know. What if I see that, just like one occurrence? Well, I might think, okay, that only happened once, like probably just a mistake, or rule out it is not really there. And what about if it's kind of like looks like episodic burst, right? So like have something, then not. So this might be, for example, typical to see if it's an acute condition, right? So you have it once, then you're cured, then you get it again, some kind of seasonal flu or something like that. Or so it would help me to know what the actual diagnosis we are talking about. Is it a chronic condition or an acute condition, right? So acute condition might look like this, but a chronic condition with flare-ups also might look like this. So things that can be quiescent for a while and people don't go to the doctor for it. So again, it's not clear depending on the knowledge. By the way, this is also could be certainly an acute condition, right? That person has it, gets cured, and doesn't have it again. So this kind of things really you need to know the context of the disease and think about it from a clinical perspective to be able to make such decisions. So more generally, when we have acute conditions, we usually can assume that a code, if we see it, it was the incidence. Sometimes, again, they come like multiple codes around the same time, related, maybe visits back, or maybe testing related to the same thing. And we sometimes then say that, okay, if you have, say, a 90-day period without any of these codes, then the next one we'll assume is a new condition. But again, this depends on, you have to know a little bit about the pathology of that disease. If you see a chronic condition code, we usually assume that that's a prevalent, that the patient had it before, it just showed up in the data right now. They typically repeat many times, which can be helpful because you can kind of usually don't need to look back very far to figure out whether a patient has a chronic condition or not. But identifying when it's incident, so when it was newly diagnosed, is actually often very hard. Usually what people do is, like in the previous plot picture I had, that if you have a long period without diagnosis and then they suddenly start up, that's how we think it's incident. So we have to think about that there must be a time period before it, that when the patient didn't have anything. Other things, again, to think about is to think about if you want to identify special incident cases, like, is there some diagnostic process that you're aware of? So maybe there are some procedures or typical treatments that should be started up at the same time when the disease started. Maybe you can look for those to identify what's an incident case, and especially to rule out things that are errors, like miscodings shouldn't have the treatment received for that condition, or if it was a rule out diagnosis, again, there shouldn't be a treatment for things that was diagnosed not to happen. So in terms of our AI models cohort, the final definition, kind of using some of those codes that we determined originally, was, and this was also not only based on kind of a discussion with the clinical team, but also on papers of what others have done. So looking at diagnosis codes that were seen in at least 2 outpatient or 1 inpatient encounter. So this kind of reduces the chances of miscoding on rule out or rule out diagnosis. They also were required to receive some specific set of chemotherapy or PIS or stem cell transplants within 180 days of the first diagnosis. This should help increase specificity for the other kind of vague codes that said other kind of amyloidoses, and that's because the other amyloidoses are not caused by malignant disease, and they are usually not treated by chemotherapy or stem cell transplant. So again, one has to need to know the clinical setting really well to come up with things like that. And additionally, to try to make sure that the incident cases are identified and not the prevalent ones, is we required at least 1 year period between the earliest encounter in the system and the first amyloidosis code. So there should be at least 1 year without any codes indicating AL amyloidosis. So this is kind of a typical thing, again, adapted for every different situation. So once you kind of figured out an algorithm, it is often a good, if possible, one should try to validate this algorithm. One way to try to do that is that actually for especially local data at MCW, one can get it identified. So you need IRB approval for that. So it's not just, you cannot do that with the identified data, but once you kind of pull the data in the identifying port, it is possible to get approval to get identified. And then you can actually do a chart review of maybe a sample of those patients that you identified, and like 50 to 100 should be plenty to do that. So it doesn't need to be everybody. And see whether actually those cases on a chart review, do they actually still seem to be the ones who you are looking for? Are they actually eligible patients that you meant to do for yours, including your study? So in a recent study that I've worked with, they had done this kind of chart review, and they found that about 20% of patients who had the code in the HR had no evidence of actually having this disease once on a chart review. So that's not clear. So those were clear miscoding. There was no evidence that anybody was thinking of that. And then when further looking, an additional 25% actually had a different final diagnosis. So it was just a code, a kind of a tentative diagnosis, but then further investigations, it was found that the patient did not actually have that condition. So now this was an extreme case because the investigator did this study because they thought it was a difficult thing to diagnose. So I hope this is an upper limit. You know, not everything is this bad, but it is definitely worthwhile looking into it because it is amazing how many the records actually do not reflect quite what's happening with the patient. And one can also look at the sensitivity if you have some kind of locally identified resource of patients who you think would be eligible. So some groups have their own little registries or just a list of patients seen by that physician. It might not be a unbiased source, but still, if you can kind of identify some patients in the chart review that who should be eligible, one can check, were they picked up by the algorithm? Right, so that will kind of allow sensitivity to be measured. There are certain, so people, you know, if one does it really thoughtfully, this is a publishable thing to publish. And so that's why another way to find ways to identify patients is to look at people who try to develop algorithm and validate them. So once we identified our cohort, one thing we might want to do is to look at their characteristics, so baseline characteristics. So some of the so-called time invariant characteristics usually are in a demographics file, which has only 1 row per patient. Most AHRs have that. So for example, for our study, we could get the age at our AL diagnosis, which we identified based on the date of birth that's in the demographic file. It also has usually race, ethnicity, sex. MCW data has gender identity, if you're interested in that. And now these are actually, you know, self-reported and kind of time invariant, though if you are studying a population where gender identities might be changing, you might want to be careful. But there are also a bunch of variables there that are really even though they are in the file that's supposed to have like constant things, they are actually not quite constant. They are more like last recorded values. So we'll have like marital status, employments, insurance, something about zip code, ADI, which is a index measuring deprivation, area deprivation index based on address. And these are very useful, but you kind of have to remember that since the EHR is designed for clinical care, and you generally want to know how to reach the patient right now as a clinician and not how you can reach them 5 years ago. So this is based on current address as last recorded. And that might be not the same as what happened when 5 years ago the patient was diagnosed with AL. So this is these are useful, but one has to use them with care and think about that. The other thing we might want to look at often is comorbidities. And really the problem with comorbidities that these are all kind of new things, and you should pretty much develop an algorithm for every one of them, which is really painful, right? So, but again, you have to kind of identify which codes are you going to use, how you're actually going to be identifying that. So one thing I sometimes see, and we have a lot of discussions on, is should we use diagnosis codes or should we use measured values, right? So for example, for obesity, right, you could use the vital signs and which have height, weight, or BMI, so you could maybe use that. So in one of our AL data pools, we had I looked obesity code showed up 22% of the time, but when we look at BMI more than 30, 40% of patients had it, which is right, I don't know. But also 25% of our patients had no BMI measurement at all, right? So like, it's not clear which is better and how to use, which one to use. In terms of using just these measures to identify conditions, I sometimes hear people suggesting, oh, we should look at the blood pressure measurements to identify hypertension, or cholesterol measurements to identify high cholesterol. But the problem there is that it's really, people take medications for those kind of SAM, and they can change these values. So just because the blood pressure murmurs, somebody still might have hypertension if they're on medication. And then you think, oh, okay, maybe we should be looking at who is taking which medication, right? Antihypertensive medication. But then, okay, and those are prescribed maybe once a year with like multiple refills of 90-day supply. So will you even see that? And what's the timing of that? And is the patient taking it, or do they just have the prescription? So it is a very, very complicated, and you really needs lots of thought, and there are no good, easy solutions. The last point about comorbidities that I want to talk more about is that you really also need to make sure that you had an opportunity to pick up the comorbidities. So this opportunity for information is about opportunity for the information to get into the medical record. And you can think about it either in time, so that like we want to make sure that the patient was at least 1 year in the system before our start date, or by number of visits. And actually for comorbidities, it's been suggested that primary care visits is a good thing, because that's when you get this kind of information in the system. But it could be just at least any visits, right? If they didn't have a visit, there is not going to be a record of anything. And this is always a balance that you want to make sure that the diagnosis is actually captured, right? If it's present, which takes time or opportunities, but also you don't include too many patients, because as you give tighter and tighter criteria, you lose more and more patients. Now, the other issue here is that this opportunity for information really should be similar among all the participants. And the problem is that if you have some patients have little short history, little opportunity for information, some patients have more, then that can bias results, because if there's lots of opportunity for things to get in the record, it's more likely to get into the record, right? So you start getting biases. So for example, I looked again in the AL data. If I look back 1 year, 27% had diabetes. If I look back 3 years of claims from the AL diagnosis, 35%. And if I look all available, it's 38%. Now that, right, as you look longer, you have more and more people get seem to have more diabetes, and clearly not all of them can be right at the same time, but it's not clear how you're supposed to do pick among them. And the problem with opportunity for information is that it biases the results even beyond this somewhat obvious thing that the longer time you have to look, the more things you are going to find. So one issue is that sicker patients tend to have longer, more stable contact with the healthcare system, right? And healthier people don't go as often. So when I took, again, diabetes and 1 year look back only, but I looked at patients who have 1 to 3 years history within the system, or 3 to 5 years history, or more than 5 years history available. The incidence of diabetes in the last year, as recorded by diabetes code, went from 23% to 31%. Because I interpret that people with diabetes are more likely to have been longer seen in the system, right? And so, but if you have people who in your study who have a mixture of different lengths of history, then suddenly you have a problem that the longer history are probably going to be sicker. The other, on the reverse side, patients who have barriers to healthcare access will probably have less contact with the healthcare system, right? Less records in it. And that's like difficult to measure. One thing I kind of to pick it up, looked at race ethnicity by years of history. And with shorter history, non-Hispanic ones from 59% to 64% when we have longer history, and non-Hispanic Blacks when the other way around. So again, so some people will tend to have more history, and you are also more likely to find things. And this whole thing is so difficult to figure out in what way things bias and which way they don't bias, because there are many things happening at the same time. So it's really important to think about these issues, about how you are going to try to avoid this or minimize these biases. You certainly cannot avoid them, but at least you can minimize by thinking about it and trying to adjust for it. So this can be, for example, done when thinking about how we would select controls for our AL amyloidosis patients. Right, so if we have for our cohort, we just want to look within it, compare groups within it, then we do not have to think about controls. But very often our study will have some, we want to compare to another set of patients. So in this case, say patients without amyloidosis, which is pretty much everyone in the database. But they should be kind of similar otherwise. So one difficulty when you try to think about controls in this case is that for amyloid patients, we had defined where is the start, is the date of their first AL diagnosis, as best as we could tell. But for control patients, they do not have a first day of AL diagnosis because they do not have an AL diagnosis. So what time we are even going to use as a baseline as their start time? So a good workaround for these situations is a case control design. And so the way it could work in this case is that for each case of patient with AL, you select controls who have an encounter maybe at the same age as the AL diagnosis of the case. And then you'll, so if the AL case has at age 40, or probably actually age 60 because it's usually older people. So you find a person who has an encounter at age 60, and that's what you will use as their diagnosis date or non-diagnosis date. You could also then try to think about what you want to match by, maybe sex, race, ethnicity. These all can affect the variables we are looking at. And then you have to to ensure that they actually have the same opportunity for information as the control, because we are going to be looking at these characteristics like the diabetes and comorbidities and other precursor conditions. So we could say that they also have to have at least 1 year of information look back window, right? Time between earliest encounter and the encounter that we will decide it was the indexed encounter. Or we could say that the history of the control, the available history for the control, should be at least as long as the available history of the case. So that kind of will tend to reduce the bias of patients with longer history being sicker, for example, than patients with shorter history available. And then in this case, maybe we don't need to have a specific look back window. We can always use the same length of history for cases and controls, whatever is available. Well, again, this is this is an example how, by thinking about the potential biases and trying to get the study design to account for at least some of them. Once you're actually trying to implement this process, it's not easy. So for the controls, because as far as I know, the current systems don't allow matching. So you wouldn't be able to implement it in I2B2 or something like that. So maybe one can try to do a two-step process, because especially, again, in this case, the control is pretty much everybody or, a really big chunk of the population. So you could download just the minimal required information for the controls. In this case, maybe encounter and demographics. Maybe ensure that they have an encounter in the time period we are interested in. They have at least 2 encounters 1 year apart, because that will be an inclusion criteria. And so at least whatever you can narrow it down, then download the data, perform the matching offline, get the actual IDs who are going to be needed for the controls, and then get the data for them, because this is going to be a lot of data if you have a lot of controls. So finally, I still have a little time, I think. So how do we actually how can we actually obtain the data at MCW? So the access is provided by CTSI, Biomedical Informatics, and really they do such a great job of supporting and making sure that it happens. So all questions should be directed to them, and they are very happy to show you these things. There is a center web page with links. The Biomedical Informatics resources link. I'll try to pull it up. So this is the page, resource links. It has links to TrinetX, to I2B2, and to Honest Broker, the extraction tools, and so on. And they have the data dictionaries, which is really important, because you shouldn't try to work with data without data dictionaries. So I'll try to show a quick demo of how to obtain CRDW. So that's our clinical research data warehouse local data through TrinetX and Honest Broker. So searching for codes, creating cohorts, and downloading the data. So the links are here to all these things, but I have it open, hopefully. So this is TrinetX, and I think you need to register for it. And so, and you can get access through Biomedical Informatics, and they can show how to use it. So hopefully it will work. Live demos are always a little bit scary. So I have created a new study, which at this point so this opens this query builder. So first I would have to select what healthcare organizations I want to use. And again, if I want to get our local data, I want to pick MCW, but they have like these other data sets that have from many, many organizations pulled together, but the access works differently for that, the extraction. So this is what I want to do. So query builder, yeah. So this is the place where it's really nice to search for code. So if I start, for example, I'm looking for amyloidosis, I start writing the word, and hopefully I not mistype it, doses, and it shows, you can click, well, there's no demographics, no well, there's diagnoses, right? It shows all the diagnosis codes, and this is ours, but I said I wanted to include some others just in case, right? But I could look at, you know, procedures. If I were to start looking for other things, it will show me what are the possible codes. One thing then I have to watch out that now it says it's and, but I really mean or they should have this or that or that or that. They don't have to have all 5 of them. Then maybe so it actually kind of has a pretty fancy interface, and you can do a lot of things. So I want to add these terms to a group. And now I have it here. And then I can do lots of things here. I could add a time constraint that a specific date that this has to happen between 1/1/2017 and, oops, I can type 1/1/2017 to some 12/31/2020, whatever is my time period. I can add that it needs to have at least, say, twice. That's not exactly our inclusion criteria, but I can do stuff like that. I can add a related group, second group that maybe I said I want them to have a chemotherapy, right? So let's start searching for, say, a chemotherapy drug. I think doxorubicin. It's just kind of slow. Doxorubicin was one of the chemotherapy agents. It's a bit slow. Yeah, maybe. And hopefully I didn't type it, but it should pop up in medications. Yeah, you see this uses the RX norm coding, which is a thing for drug. This is the code, and I can select that. That's what I want. And now I can move this term here and say that, okay, and this relationship is that the first instance of the diagnosis called and any instance of the chemotherapy should be within, I don't know, 180 days, something like that. So I can do a lot of kind of this building of the cohorts in this database. And again, it kind of helps really with helping with the codes. If you start searching here something, it will show all kind of codes that you could be thinking about. So I actually created a cohort. This kind of saves the cohorts along the way. I did create a cohort with a longer kind of that they have to have an ambulatory visit at least 1 year before that to have a history. And then they have one of these many chemotherapies within, okay, up to 1 year. So you could, and then maybe they do not, this is an exclusion criterion, and they should not have any of the other conditions. So you can create fairly complicated logics here. And then to request it, you first have to, I think, run count patients to actually get the number. You know, I will found 190 patients at MCW at one HCO. And I can click this and it tells export patient IDs. And so if I'll go back to my presentation. So if I click export patient IDs, what I'll get is a zip file that I can download. Right, so I'll get a password protected zip file, and it will have a bunch of, I want to show, this is how it will look like once I open it, like lots of patient IDs. So at this point, these are encrypted, so it's not, we don't know who these are. At this point, I go to Honest Broker, which is, again, link. It is linked from the Bioinformatics page, but I have to go there and I can sign in. So it's a different system. And then I say, I want a de-identified extract. And I pick that I got my numbers from TrinetX. And pretty much copy paste over that big, from the spreadsheet, the big list of numbers. And these are the numbers I get. Then these are all the kind of variables that data type that we can access. I click which one I want. And once I submit, after a while, I'll get this ALM data set, and it takes a while to show it up here. And then I can download and obtain it. And it will look like the data set kind of I show at the beginning, that it will have many CSV files in it. And I put them into one Excel sheet, some of them, just to show it with all the diagnoses, demographics, diagnoses, medications, and all the other things about these patients. So, and there you have it, you have your data. Of course, the problem is, of course, that this data doesn't actually identify which was the first day of AL diagnosis that got identified by TrinetX, right? There is no link that this is the one that make it happen. You get all the diagnoses. So essentially, after you get it, you have to reprogram all your inclusion criteria to actually identify them in the database. So just to wrap it up, one thing to remember that with the HR data, perfection is impossible. It's full of errors, omissions, just happen, because again, the process of getting data into it is so imperfect and depends on so many things, so that there will be always biases. But you really want to think about it, and I think you can reduce biases by considering what makes things to pop up in the data. Would you know or not who is more likely to show up, who is less likely to show up, and so on. And whenever you actually want to get a cohort, you essentially need to develop a detailed algorithm, and it is hard. And any kind of new piece of information you want, you need an algorithm. I think you should definitely consider doing a validation study, because these algorithms are really difficult to make sure that they're right. And again, think about the biases, like in terms of health status, like sicker patients, healthier patients, but also disparities to healthcare access will be magnified in this kind of work. And opportunity for information. So if you don't see anything, are you sure that it didn't happen? You have to make sure that you've given it opportunity to show up in the database. And finally, obtaining EHR data, I think, is easy nowadays, in the sense that our informatics people worked very hard to make it easy. So they have provided the infrastructure to get the data. But then refining the cohort, working with the control sets, often you then have to do it offline. After you obtain data, there's a lot of still potential work. And converting to an analytic data set, all those spreadsheets, and actually getting out into a data set that you can then analyze and run stats on, again, is a lot of work. And that's kind of the topic of Dr. Huang's talks in 2 months. So this is not a straightforward thing, and you kind of have to be ready for it, that just because it looks so nice and easy in TrinetX, and there are so many things you can do, but if you need to do anything you cannot do in TrinetX, that's a lot of work. It's not as easy at all like it looks like in TrinetX. And that's it. These were some references I used to put together this talk. And thank you for your attention. I know I'm kind of at time, but if you have time, I'm happy to take some questions.
Hey, Aniko, thanks for your presentation. I have a quick question. We've found it really necessary. We've used I2B2 and Honest Broker to try to find cohorts and pull data. And we found it really necessary to just do a lot of manual chart review of all the cases that come through to see if they're actually eligible for the studies we're looking for. And it's been a difficult process to really learn more about these Honest Broker data extracts. We kind of do it through deduction, right? By comparing what we see in the EHR to what we see in these exports. One thing we've wanted to do is when we are screening, we're looking for patients, say, who came to the ED with a concussion, right? And so we go into Epic and see if they meet criteria. And then we want to be able to go back to the Honest Broker extracts and pull the associated fields from those encounters. Do you know if there's a way when we're looking at Epic to see the encounter ID so that we can use that to pull the correct data from the Honest Broker extracts?
I thought I saw Kristen there.
I know
because she's the person to
might be a better question for her, but
yeah,
Hi. No, that's a really good question. And currently the Honest Broker does not allow for input of encounter ID, but that is something for us to consider. So thank you for bringing it up.
Yeah, I mean, the encounters output file provides a lot of, we get way more data on the patients we've identified than we want, right? And we're trying to narrow it down. So when we're screening Epic, if we could write down an encounter ID and then use that to just merge in what the subset of information we wanted from the Honest Broker extract, that would be helpful. Right. But basically what Honest Broker provides doesn't resemble what we're looking at in Epic, which makes it difficult to kind of combine.
Right. And that's an inherent difficulty because Epic is designed for you to look at one patient at a time with a broad scope, whereas Honest Broker tables are more kind of brute force domain tables for then you to do stuff like Aniko just did. So it's a different orientation, certainly, but you raise a really good question. And so I'll discuss that with our data engineers and our system engineers to see what kind of tooling we might be able to consider and let you know, because if we are able to, I'd love to have your opinion on our design.
That'd be great. We've been spending a lot of time with these tools in the last few months. So I would love to be part of any conversations that would be helpful. Thanks, Kristen.
Great. Thanks, Lynn.
Yeah. But your point about that validation, yeah, I think is really important.
Yeah.
And in similar vein, one thing that I find frustrating that you got data from CRDW, and they have a lot of data, a lot of information, but you also can get from the same TrinetX query, I can just change that I want all other organizations, and I can get lots of data through TrinetX, and they have a different format. And so even if you thought you have an algorithm one, or at least certain the program is not going to run, even if, in conceptual, principle, you could apply one algorithm. It's just they have a different format, and everything has a different format.
Yeah.
So
yeah, we went into it with thinking naively that we would figure out the best way to search I2B2 for cohorts and learn and refine our search algorithms. And what we've discovered is exactly what you've talked about today, which is that there's just inherent challenges to EHR. It's going to bring in cases that we don't want. We have to look physically at each case in Epic to figure it out. But that being said, I'm still hopeful that if we can learn more about what Honest Broker is telling us, that we'll be able to do a better job with less effort.
any other questions?
Well, thanks, Aniko. Thanks for putting this series
Well,
together.
Thank you, everyone, for attending, and I hope you come next time too. Everybody who registers should get an invite. I think that's how we set it up. So if you hope this is useful to you. So thank you.